Welcome to Raise the Line with Osmosis.org, seeking solutions with leading experts on how to increase healthcare capacity so people can get the care they need during the COVID-19 crisis and beyond.
Hi, I'm Shiv Gaglani, and today on Raise the Line, I'm privileged to be joined by Dr. Ken Johnson. Dr. Johnson has been the Executive Dean of Ohio University Heritage College of Osteopathic Medicine since the summer of 2012. In addition to his duties as Executive Dean, in January 2018, Dr. Johnson was chosen to also serve as Chief Medical Affairs Officer for Ohio University. Nationally, he is active in educational policy and holds numerous leadership roles within the osteopathic medical profession. So, Dr. Johnson, thanks so much for being with us today.
Oh, thanks. It's an honor to be here, and you make me sound like a busy guy.
I think you probably are busy, and maybe even busier now in the past few months, given all that's going on. I'm curious, how did you get involved in the medical field? What was your pathway to becoming a doctor, and specifically in osteopathic medicine as well?
Yeah, I think I was always really interested in health and wellness. This will date me a little bit, but my mom bought us the Encyclopedia Britannica, and I was always really interested in anatomy and physiology and things like that, which I think sparked my interest in health and wellness. And then really wanted to become a physician. I grew up in Massachusetts. I didn't really know much about osteopathic medicine. And then after graduating from undergrad, discovered osteopathic medicine, and the philosophy and the approach was right up my alley. It was absolutely what I believed in, what I wanted to do. And that's what drew me to osteopathic medicine and to, eventually what I'm doing here now.
That's awesome. I'm curious, so how did you go from practicing medicine to then getting into academic appointments and more leadership roles?
Yeah, I actually all through medical school, I had some teaching role. I actually did an undergraduate teaching fellowship in medical school. I spent an extra year teaching anatomy and osteopathic manipulative medicine, and that really sparked a love for teaching for me. I was drawn to it, and then as I entered my family medicine residency, had a lot of opportunity to teach, particularly as a senior resident to junior residents, and for some reason didn't really think about becoming a teacher until the residency director for the residency that I was in said, "Hey, did you ever think about being a faculty member?" And I was like, "No, but that sounds good to me. Tell me more." And practiced in a family medicine residency for about a decade, was the chief medical officer in a rural setting, and then got more into the medical school training here over the last about 15 years or so.
So osteopathic medicine as a field has grown tremendously. We had Dr. Kane from ACOM on a couple of weeks ago, and he was telling us a bit about this. But I'm curious, from your perspective, when you first started as a medical student, do you know about how many schools and students there were? And now,
Dr. Kane and I are somewhat contemporary. So we had about 15 colleges of osteopathic medicine when we were in medical school, and there's about 50 locations right now around the country. 1 in 4 students of medicine are osteopathic medical students, and we're the fastest growing healthcare profession in the United States today.
Wow, that's amazing. I mean, and one thing I was curious about too is, there are a lot of professions that start in the U.S., like nurse practitioner or osteopathic medicine. Are there plans for DO programs to expand internationally as well?
Yeah, we've been working as a profession for more than a decade for full practice rights for osteopathic physicians around the globe. There's many countries that have that in place right now, and I think early thinking among a number of people around bringing the osteopathic approach to healthcare, the medicine approach worldwide.
That's great to hear. So going into your role at Ohio University, would love to hear a bit more about, the path from 2012 to now, kind of how you, what you basically have done on a day-to-day basis, because you wear a lot of different hats and you are busy. So what does your day-to-day look like at this point?
Yeah, well, I was recruited to Ohio University to open 2 new medical school campuses, one in Central Ohio with Ohio Health and another in Northeast Ohio in Cleveland with the Cleveland Clinic. So we went from 1 to 2 to 3 campuses in a very short period of time. It led us to be the largest public medical school in the state and only multi-campus medical school in the state. I feel really blessed to have great partners. I just got off a video call with leadership of Ohio Health right before this and planning elements of our partnership together. But what it's really allowed us to do is we have a statewide footprint for our academic campuses and placing students really around the state of Ohio.
That's one of the mandates, is to maybe have as many students from in-state enroll in the program, or at least people who come from out of state to stay in state and practice in rural
Yeah,
settings?
it's both of those things. So we very focused on osteopathic on primary care as our goal. Is really was why we were founded. Draw our students from the state, training them in the state. I think an interesting piece of the medical school is that 30% of our students are the first in their family to go to college. Not medical school, college. So we draw students from rural, underserved, underrepresented, and bring them in and have some good pipeline programs to bring them in and support them. But I think that's part of our secret sauce of our success of placing students in the communities, because we draw them from the communities, train them in the communities, and they stay there. Our central and northeast Ohio campuses, about 80% of the students are from a 1 hour geography from around those campuses, which is a pretty unusual thing when you think about medical school and drawing students from a bunch of different places around the country.
That's an incredible statistic. The 30% are first generation college students,
Right.
and their families, let alone medical. Very
Yes.
impressive. We Another guest we had on Raise the Line a couple months back was Ted Wendell at AT Still University, and we're pretty close to Ted and Craig Phelps at ATSU.
Oh,
And
yes.
they similarly talk about attracting students from the communities so that they're more likely to stay in those communities, because there are some discussions that we don't actually have a physician shortage in the US. It's more just distribution. However, it's probably a mix of both, but I'd love to hear your thoughts on that.
Yeah, osteopathic medicine is really interesting because you find osteopathic medical schools in the most unusual settings. So we sit in Central Appalachia on right now, along with about 3 or 4 other osteopathic medical schools, most of which are sitting in towns of like 3 or 4 thousand. And when you think about, hey, where will I put a medical school? Let's put it in a little rural town. But that was what osteopathic medicine was founded to do. I mean, it was never really intended to be a separate form of medicine. It was intended to improve the system of medicine of the day. When you think about it, in the late 1800s, the common treatments were like leeches, bloodletting, et cetera. And the founder didn't want to start a new system of medicine. He just said, "There's got to be a better way to treat patients." So on here, when you look at osteopathic medicine and where we exist around the nation, we tend to exist in places of greatest need, founded out of that need. Here, one of the great success stories, the Ohio Osteopathic Association voluntarily raised their dues for 2 years to help us start the medical school here in 1975. So we have this like really strong input from the community, from those areas, because of that need for primary care physicians. And I do think you're right. I do think there's a combination of maldistribution and also just kind of the greater need for primary care on physicians. I do think it's a little bit of both of those, and solving the problem of how do we get physicians to practice where it's needed the most is hard.
Especially with some of the trends we're hearing about with regards to rural hospitals closing. That's been going on for some years as health systems have consolidated, making access to care even harder in these rural settings. I would love to hear kind of what you've seen over the years, and then let's get into COVID and how maybe that's accelerated some of the trends
Right.
that maybe you've been seeing.
Yeah, so part of my background, I've always been involved in training people to care for people where it's needed the most, and focused on primary care and or actually delivering that care. So I was a chief medical officer for a rural health network in Maine, and I joke around that I had more moose than people in my network. So how do you care for people across the geography when you don't have things like transit and other things like that to be able to care for folks? So there, I think you're talking about creating unique solutions to really help people. So one example we have at Ohio University is we have 2 mobile clinics that we send out across. Ohio has 88 counties. In Southeast Ohio, we covered up to 27 counties across Southeast Ohio, where we show up in the VFW parking lot or the library or whatever, where we bring nurse and physician or nurse practitioner to provide primary care or immunizations or whatever the community needs, and partner with others. We've had partnering with Ohio Health, where they have a mobile mammography unit, and we show up and we run the breast and cervical health program. And they come in, they get screened, they go right next door, they get a mammogram. And I'm so proud of programs like that. I've run, and I was at the Race for the Cure that we had in Athens, and one of the survivors, who was the marshal for the day, talked about how her life was saved one day from that, literally showing up at our van and immediately getting a mammogram and finding out that she has breast cancer. So some of this, I think, is bringing care to the people, and then I think others is really just coming up and trying to expand on unique modes that allow access.
Speaking of one of the unique modes that's gotten a lot of attention over the past few months because of COVID and the need for social distancing is obviously telemedicine. And so
Yes.
we've spoken to several health system leaders as well as Joe Kvidar, who is the president of the American Telemedicine Association, about what parts of telemedicine are here to stay versus maybe will revert back to pre-COVID times. Would love to hear your thoughts. I mean, how are you thinking of training your students, your preceptors and faculty with regards to the need for virtual care and telemedicine now?
Yeah, this is something we've been thinking of very deeply ever since I came to Ohio. We had a grant that was just finishing its last phases when I first came here, helping rural practitioners adopt EHR, which is kind of the earliest phase of shifting into electronic care. And then I tried to do things like in our Dublin campus, we partnered with a local telehealth company that was very innovative in the way that they were trying to create a space that patients might resonate with a little bit on better to get that kind of remote care. But the reason I did that is I wanted our students and faculty to be thinking about what this care delivery looked like in the not too distant future. And I joke around that like the modern stethoscope is on, your iPhone. No provider can work without it. So the interesting thing about COVID, from my perspective, and I think that you've seen this in your other conversations, is that it's really accelerated on telehealth. And our partners, in my conversations with folks leading, say, the Cleveland Clinic or Nationwide Children's Hospital that we work with a lot as well, it's kind of like no going back at this point. It's really, it's accelerated and opened a door, or maybe better, opened a window to allow us to provide care in a timely way and where it's needed the most. Now, what I'll say is there's an area that I worry about with telehealth. So the osteopathic approach is a very, kind of hands-on, holistic approach. But the basis of on osteopathic medicine, we don't own what I think is part of one of the most necessary things in healthcare delivery, which is care. And so we know that if the patient answers this simple question, my doctor knows me as a person, they're 8 to 9 times more likely to follow through with their instructions. So my big question is, when we're in this like 2D world and meeting for the first time, how do you establish a caring relationship with someone who they feel cared for as a person, and then that they would be more likely to go ahead and follow through with your recommendations? So I think there are some things that we have to do to evolve on how to do that. And I have a few ideas for you if you'd like me to share them.
Totally. No, I would love to hear how you're thinking about that. Like, I mean, I would love to hear how many students and residents you have too at Ohio, because how would you
Yeah.
train them to have what's called, proper website manner? It's not just, bedside
Yeah.
manner now, it's
Oh,
website.
yeah, that's a good way to think about that. Yeah. So as we grew, we have 1,000 students across our on 3 campuses and affiliated with many on graduate medical education programs here around the state. We have about 3,500 clinical faculty on across our clinical on rotations. So we've grown to be a really pretty big enterprise. And we actually do our education across our 3 campuses simultaneously using distance education. On the student side, I tell our students that they're digital natives. I mean, it's just not, when we first launched our first new campus, I wanted to create an environment where we had a window across each campus where a faculty member could be in one space or the other, simultaneously teaching on both. And then when our third campus, we just continued that on. I wanted high fidelity, both video and sound. And I knew I had accomplished what I wanted when I was on our Dublin campus. I normally am on our Athens campus. And I heard one of our faculty teaching. And I walked down the hall and he was teaching from Athens. And it just sounded that good. I thought he was in the room doing the lecture. But medical education, pre-COVID, we were doing simultaneous connected and distant education, connecting our campuses so that we could have a cardiologist in Cleveland talking to 250 students in Cleveland, Dublin, and Athens all at the same time. So we've been doing some kind of distant education like that for a couple decades with our distributed network of students around the state for clinical training. And pre-COVID, it made us think about what's the future for telemedicine and what does that look like. So I think we had a good basis for that. With COVID and what I've seen, it made me think about that even more. So a couple things I think about is a question like, how do you establish an empathic relationship with distance? And I think there are ways, like your web rules that you have, but it may be telemedicine is here to stay. It's going to expand. I mean, I joke around with my students that we'll have an eye device that you just put down on the table and a holographic 3D picture will come up. But we actually worked with a company that did some holographic work where patients respond a little bit better to 3D than 2D. But that's a joke. You'll have that as the future piece where we continue to move forward. But my belief is that you have to spend some time with some very specific connecting points on two patients, and maybe even need to change the way you communicate in paper with them electronically or whatever. There's a community health center that does that end on really pretty well. And it may sound, kind of a little hokey or funny, but they've changed even the way they put out their lab reports that says, Dr. Smith cares about you. Your cholesterol is elevated. And because he cares about you, you need to follow up. So it's not just the cold, hard facts that they're reporting. They're transmitting that the provider has a deep caring relationship for the patient. So I think we have to be really pretty specific at changing. We can't just be 2D talking heads at the end of a screen or just transmitting facts that you can look up in my chart or whatever else you're looking up in your phone as we shift more and more care into that more virtual environment.
Yeah, no, I completely agree with that. Before I started Osmosis, I was in medical school as well. And there are a lot of transferable skill sets. Like when you meet a patient, how you make them feel comfortable is similar
Right.
to when you meet a potential teammate or anyone really new. How do you make them feel comfortable and open up, right? And when you notice body language or facial expressions, micro facial expressions that you want to double click on, right? If they, it's that paradigm question when a doctor's about to leave the office. Oh, doctor, one more thing, right? Like you want to elicit that because that
Right.
one more thing could be like the thing, right? That you need to hear. How do you do that on a Zoom call? So it is a really interesting challenge that you all are facing. What are some of the other kind of challenges you faced because of COVID, and how have you addressed them?
Yeah, so the biggest challenge was just as COVID was sweeping across the globe and coming to the United States, in which I was engaged in the university's response from that in my chief medical affairs officer role. We have faculty and students all over the globe, either doing research or training or on doing study abroad, as we had to withdraw and pull them all back and think about how do we keep people safe and bring them home locally. Things swept across Ohio really pretty fast. There was a Friday where every medical school in the state of Ohio had students on clinical rotations. And by Monday night, they were all off of on rotations, pulled them off just as PPE was becoming more limited. We weren't so sure that students were safe in the environment. They were being limited on the experiences that they could have. So, one of the things I'm really proud of that we did was on that weekend, I called the Ohio Department of Health and I said, I have a crazy idea I'd like to run by you. And, what is that? I said, well, what if we trained all of our third year medical students in public health and deployed them to the 88 counties in Ohio to assist in the public health on response? And then I called my other good friend, Dr. Kane, and I said, hey, Bob, I have a crazy idea for you. He loved that idea as well. And we actually put together kind of a national consortium that has allopathic, osteopathic medicine, PA, MPH, et cetera, talking about how do students assist America on right now. But we did the pilot of that, which is using that group. We were turned on to one of the other colleges that had a 20 segmented training, 20 segments for COVID, everything you can imagine, the epidemiology, special circumstances of pediatrics, OB, et cetera. So we put together in a 16-day period of time a clinical rotation for COVID, where students were then deployed to public health, Ohio Department of Health, the National Guard, and were engaged in that process. So it was my trying to make some pretty good lemonade out of lemons, and I thought that students having the experience of COVID directly was the right thing to do. So that was our early experience, and then we've transitioned all of our students back into clinical rotations right now. The goal's been to keep students in clinical rotations kind of regardless of the clinical environment, as long as it's safe, and working with our partners to ensure that. And then on the medical school right now, we're working in a hybrid model where all students for their face-to-face activities are clinical skills, OMM lab, and anatomy. And then everything else is really being done virtually here right now. We've learned a lot. And I had a meeting with my student leaders this morning at 7, and they report that that's all going really very well for them at this point.
That's awesome. I mean, creating a whole rotation in 16 days is no small feat. And a quote I always have shared with the team pretty frequently is actually from Lenin. He said, "There are decades where nothing happens, and there are weeks where decades happen."
Oh yeah. Oh, I feel that. That's a good one. I like that one.
Yeah, I'll make sure to send it to you. But
Yeah.
yeah, okay. I mean, for example, at Osmosis, we created a 3-hour CME COVID course in about a week that we were only planning to do continuing medical education in like 2021, but we're like, wow, like
Right.
there's a real need for this. And now we
Yes.
have a mechanical ventilation course with a partner called Laerdal, which makes mannequins and sim center dolls. Yeah. So it's a very interesting time. I think it's the pace of change hopefully will stay. Those circumstances will hopefully calm down.
Right. Right.
Given that you are a physician and you're a leader in education, what advice do you have to early stage healthcare professionals, your students, about dealing with the current crisis, as well as the long term prospects of a career in healthcare?
Yeah, a couple things. So when I was orienting our new first year students, actually before they came in, I said that we are now literally, as opposed to figuratively, training you for your profession the day you walk in the door. So I mean, all of our students are coming in with masks, social distancing, washing hands, et cetera. So my goal for the medical school in general was that we operate regardless of the environment around us, and that we're training our students for the healthcare environment as they enter medical school. One of the things that I strongly encourage our students to do, we have a great relationship, and I try to have them give us feedback as they're walking through the process. They have great ideas on about how to evolve things, how to work on things. And I challenge every single class that comes in to give us the feedback to improve the process for them. I think one of the things that's a little tough to deal with is there's a natural element of fear and anxiety in this. I mean, because healthcare workers are on the front line, they're the ones that have a greater likelihood of getting exposure. So how can we give them the added skills for them to be safe? This is the time that they're needed the most, without a doubt. And students are extremely creative, and I try to find ways to tap into their creative potential. So in their altruistic side, the volunteerism that they're doing, on ways that they can do that in this environment. And then I really feel like that there's no better or more needed time for us to have on medical students in the profession. So I guess my advice would, don't be shy on in giving your respectful feedback on as you're walking through your program.
That's great advice. I wish more medical education leaders expressly stated that. In fact, when I was a medical student, sometimes we felt a bit rebellious creating Osmosis.
Oh, so when I was a medical student, you had a lot of people with their glasses on looking down at you. Did
Yes.
you really say that? Is that what you meant? So
Yeah, no, totally. And that the sort of hierarchy I think applies clinician to patient, and oftentimes
definitely.
turning the patient into an empowered consumer of their own health and provider of their own health is really, I think it's also a macro trend we're seeing with the rise of direct to consumer type healthcare. There's clearly an advantage to that where people get engaged in their health, they understand it better. But then there's also the negatives of maybe they become cyberchondriacs, as one would call it.
Oh, that can definitely happen, right?
Yeah. Well, I mean, I'm really impressed with everything you guys have done at Ohio University. And again, I've taken you well over your time for this
Okay.
podcast. But I'm curious, my last question is there anything else I should have asked that you'd like to be able to share with our audience?
No, I guess I would just close with thank you for the appreciation of our medical school. I feel like we have a very special program that we have here. You know, our kind of tagline is "Care leads here," and we think about that in a few different ways, which is we're producing kind of the future leaders of healthcare. So I want them to be in kind of that leading role, but taking a caring approach to that. We start with our patients, you know, in caring for them, and then probably one of the important things in training is we try to create a caring environment for each other here. It's medical school is very hard, it's very stressful, and we try to create a supportive environment and encourage folks to be supportive of each other. So I'm very, very proud of what we're doing at Ohio University and with our faculty, staff, and just truly phenomenal students. I joke around with them a little bit. I say, I can be your executive dean. I'm not sure I could be your peer. I mean, they're just so phenomenal. They're bright, they're kind, they're caring, altruistic. And my meeting with my student government this morning was really around, I try to tell them, how can I support you in being student leaders? Because, they set the tone for the class, and they can really kind of help their peers be, just truly phenomenal. And medical school's hard, and we don't have to make it harder. I think there's any way we can make it easier. And I guess one last thing that I really believe in is that medical school can really be a transformative time for people, and transformative in the sense of, I feel like it's my job to give students opportunities to change as a person and to help them with that, kind of along the way. I mean, certainly giving them the knowledge, skills, and attitude. But when you have an experience where you're holding the hand of a dying person in hospice, or delivering a newborn to a couple that's been wanting a baby for 7 years, I mean, those are really incredible periods of time and truly transformative. And there's the good and the bad and ugly of all of that, which is it's really stressful. And we know there's a lot of burnout, anxiety, depression, suicide. With that, I think that if we can create an environment of support and recognize that and help our students be really resilient through all of that, that they'll be really successful and fulfilled in their careers.
I couldn't agree more. I think there's a national recognition of that, and it sounds like you guys are putting a lot of things in place to actually turn that into reality. So with that, Dr. Johnson, I'd really like to thank you for your time today and the insightful conversation.
Yeah, I thoroughly enjoyed it, and thank you for the really great questions.
Awesome. And with that, I'm Shiv Gaglani. Thank you to our audience for checking out today's show. And remember to do your part to flatten the curve and raise the line, since we're all in this together.
For more information on how you can help raise the line and flatten the curve, go to osmosis.org/COVID-19. If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our podcasts at osmosis.org/raisethelinepodcast.